So, dear participants, I'm pleased to welcome you to the first CAMS Menopause Hour, the Council of Affiliated Menopause Societies of the IMS, organized today by both the Swiss and the German menopause societies. The title of today's educational session is Perimenopause, a Clinical Challenge. A little about myself. My name is Susanna Weidlinger. I was born in Austria, but have spent my entire working life in Switzerland. Currently, I'm working at the Division of Gynecological Endocrinology and Reproductive Medicine at the University Women's Hospital of Bern. And since this year, I'm the president of the Swiss Society for Menopause, Contraception, and Gynecological Endocrinology. Now, I would also like to welcome the two speakers. Firstly, Dr. Schaudig with her presentation, Perimenopause, Ovaries Out of Control. Dr. Schaudig is a German gynecologist in a private practice in Hamburg with specialization in gynecological endocrinology. Since 2020, she is president of the German Menopause Society, and she regularly contributes to national and international medical conferences in the field of menopause. And then secondly, there will be Dr. Bachmann with her presentation, Peri- and Postmenopause in PCOS patients. Dr. Bachmann is the head of the Division of Gynecological Endocrinology and Reproductive Medicine at the Department of Women's Health in the University Hospital of Frankfurt. She is a board member of the German Menopause Society and is committed to women's well-being in all phases of reproductive and post-reproductive life. I would also like to mention that this online event has been supported by an unrestricted grant from Abbott. Abbott has no role in the section of topics or speakers and has not vetted or reviewed the content on the speakers' presentations. And now I would say we go straight to the presentations. Katrin, you have the floor.
Yes, thank you, Susanna. First of all, I say hello to everybody. And thanks a lot to CAMS and especially to Claire, who prepared all this session and gave us the opportunity to be here. And again, and Susanna, thank you for the kind invitation. And I'm very happy also with my co-speaker here, Annette Bachmann. I'm sitting on the board of the German Menopause Society together with her. And we're very happy to present in the next hour two very important topics. So the main topic of this session is challenge perimenopause, and we feel that the perimenopause is the biggest challenge while treating patients in this phase of life. So I start with my disclosures. Here they are, which is just that you can see. And now what period are we talking about? And there is the staging of reproductive aging according to the WHO straw criteria, and that has been done very nicely by a workshop about 10 years ago, where people were considering how is the reproductive lifespan well categorized, and because there have always been some insecure issues about that. So what you can see here, the reproductive lifespan, which is about 35 years long, is you can see here several parts of it: early, peak, late, and then comes the menopausal transition or perimenopause, which you can see here. After the final menstrual period, we talk of perimenopause for one more year, but then with the final menstrual period, the postmenopause starts, and we define the final menstrual period or the menopause as the last bleeding in a woman's life that is not followed by another bleeding for 1 year. As you can see, the early perimenopause has a very variable length, and it can last like up to 10 years, where the late perimenopause, that is a period of time where it is kind of, the last bleeding is also already in sight and in view. So this is the period we are talking about. And as this is not so visible, we made another I made another graph to kind of illustrate what is happening. So these are, again, the stages during perimenopause. So we start with the late reproductive period. The cycles are still regular, slightly irregular, and FSH is normal, or it can be just sometimes be a bit high. The ovarian reserve is already low. Now starts the early perimenopause. The cycles are variable. FSH is still normal, and that is very important. If for whatever reason the patient has some lab results done, the FSH can be normal in this time. Sometimes you may hit a point where the FSH is elevated, but that is just by chance. The ovarian reserve, of course, is persistently low. And if we look at this, cycles variable, that is defined by the Straw authors that it is more than 7 days variable in cycle length, or there can be phases of amenorrhea up to 60 days. So that is the definition of the early perimenopause. And I think this phase is very crucial to be recognized by us when we treat patients, and not telling them, oh, you're still bleeding and your FSH is normal, you cannot be climacteric. No, this is not true. That is the phase of the early perimenopause where women tend to have complaints. Now comes the late perimenopause, and remember from the previous slide, that is like 1 or 3 years, whereas the early perimenopause may last something like 5 years, like 7 years, 10 years. So in the late perimenopause, the cycles become more irregular and prolonged, and they may be more than 60 days. There may be breaks of bleeding of a couple of months, even half a year. So that is late perimenopause, and we're really heading towards post-menopause here. In this period, you most of the time find an elevated FSH. The ovarian reserve now is very low. And after the final bleeding, which would be like here, you have the post-menopause, the menses have ended, you have a continuously high FSH in a high range, and the ovarian reserve is very low or undetectable. So this is the period now, with this red equator that we are talking about now. So when we talk about the perimenopause, we first have to think about the cycle in the reproductive lifespan, and which you see here is the levels of estradiol and progesterone throughout the female cycle of an average of 28 days. In the middle, you see here the ovulation, and what you can clearly see in the first 14 days before the ovulation, we only have estradiol in the cycle, and it is where there's an exponential rise of estradiol up to the pre-ovulatory point, and that you can see in picogram per mil. It's 300 picogram. It's a very high level. Then with the ovulation that occurs here, the estradiol level goes down very deep, and then it stays there in the middle level for the rest of the luteal phase. And most important is, with the point of ovulation, we have a very big production of progesterone. So we have a lot of progesterone in these 14 days. If there's no pregnancy, both hormones decrease to the basic level, and the whole thing starts again. So this looks like very complicated. It's like a flow of hormones, but it's very regular, and it's got a big fine-tuning that this works out every month with the goal that a pregnancy is achieved, which of course does not happen every cycle, but that you always have to keep in mind is the goal of evolution. So according to this slide we just saw, we have the elevation of the gonadotropins, LH and FSH, that precede the ovulation. So this peak in LH induces ovulation, as you all know, and this is the range of these hormones throughout the cycle. And again, it's a very nice fine-tuning of these hormonal development throughout the cycle. So the female menstrual cycle is regulated through a constant dialogue. And what are the players of this dialogue? So it's the hypothalamus, including the GnRH neurons and the KNDy neurons in the arcuate nucleus. So they're very close to each other in proximity, and they are the main, well, pulse givers that kind of define what is happening in the cycle. So they give their signals to the pituitary gland, and from there the signal goes through to the ovaries. So which are the messengers of the dialogues? So that is GnRH, which is produced from the GnRH neurons, FSH and LH, which is produced in the pituitary gland, and then, of course, in the ovaries, estradiol and progesterone. But also in the ovaries, we have the production of inhibin A and B and of AMH, which, as you know, reflects the pool of the follicles in the ovaries. Most important now that we have learned within the last 2 decades are the KNDy neurons that secrete kisspeptin, neurokinin B, and dynorphin. And meanwhile, we know that they are the crucial signal givers to the GnRH neurons and tell them what they're going to do in the cycle. So now here you see a graph, which is a schematic picture of how it is controlled. And so there you see the GnRH neurons, but as you can see, they are mainly influenced by the KNDy neurons here, and the KNDy neurons are the ones that have receptors for estradiol and progesterone. So again, the GnRH neurons give their signal to the pituitary gland, and from there on to the ovaries, and from there comes back a signal to the KNDy neurons, which tells the KNDy neurons up there what is going on. But also the inhibin A and the AMH that are produced in the ovaries give the signal to the KNDy neurons, and via KNDy neurons to the GnRH neurons, how they have to stimulate the cycle. The action of AMH in the postnatal ovary, that is kind of very important to know. AMH is not secreted by the primordial oocytes, but the primary and preantral and small antral follicles. As soon as AMH is secreted, the secretion of FSH is inhibited. So the number of follicles in the ovaries determine the secretion of FSH. So when there are many follicles that produce AMH, FSH is low, and the lower the follicle count in the ovary becomes, there is less inhibition of FSH, which leads to more recruitment of follicles. So in the normal fertile range, AMH inhibits initial recruitment and inhibits the stimulatory effect of FSH on the growth of preantral and small antral follicles. So, but now it's easy to understand when these inhibiting processes decrease because of a decrease in follicles in the ovaries, the whole dialogue that we were just talking about is getting confused due to the significant reduction of the follicular reserve. This extremely fine-tuned circle doesn't work anymore. So what does happen? Through this dysregulation, the cycle is not well organized and synchronized anymore properly, but suddenly it can happen that several follicles grow because the pituitary glands and the hypothalamus think, oh my God, what's going on down there? It's not working properly anymore. And that is a very nice study that has been done like 12 or 14 years ago, where one has measured the estradiol and progesterone levels of women in the perimenopausal stage. And you see here the days of the cycle, and the gray area is the bleeding. And what you see here in this example A is we have a rise in estradiol, like what I just showed you in a normal fertile cycle. Around mid of cycle, we have an elevation of progesterone, a rise of progesterone. But suddenly, in the middle of the luteal phase, we have another rise of estradiol. Obviously, a second follicle started growing in this second phase of the cycle, in the luteal phase, and leads to a second ovulation during menstruation. So this is something we learned cannot happen, but obviously in perimenopause, the controlling of the process is disrupted, and we can have several follicles within, let's say, a couple of weeks starting to grow and to develop. So example B shows something similar. Again, we have a second ovulation, which is marked by these dots with progesterone secretion during the menstrual period. What you can see in example C, several follicles are rising. We have a high estradiol level during menstruation, but no second ovulation, no progesterone secretion. And example D, we have a lag phase of like 4, 5, 6 weeks where there is no follicle development, and then suddenly 2 follicles develop, and then 2 ovulations in short time. So this is really very well, for the women it's a challenge, and for us doctors also, and it's spring tides and tsunamis, and which kind of makes problems for the women. So there's another graph to illustrate what I just told you. So that is the fertile phase, follicle growth, ovulation, luteal phase, very nicely and regularly. So in the perimenopause, the cycles become shorter or longer. That is the variability that I was just talking about. And here you see are also cycles without any ovulation. And what I show you down here is during the luteal phase, we have the growth of a second follicle and the ovulation during bleeding time, and there is a third follicle growing, and it takes some time until the next ovulation occurs, which shows there is a whole, well, it's complete chaos in the regulation of the cycle. What does this, and what this is called is that when there's an ovulation during menstruation, the authors of the work I just showed you have call that it's a loop event, a luteal out of phase event. What does this lead to? Of course, you can easily imagine it leads to bleeding disorders, and it also may lead to symptoms of estradiol dominance, mastalgia, edema, etc. What else is it? Symptoms of estradiol deficit, because there are also periods, like in example D, where you don't have an estradiol secretion that leads to hot flushes. Sleep disorders, very, very typical. Irritability, mood swings, depressive episodes. And there's a very nice work by a study by Roberta Brinton from California, where she showed which systems are affected by the perimenopausal transition in the brain. And you see a whole lot of systems are impaired by this. And that can lead to cognitive dysfunction, insomnia, mood changes, and sometimes only one of these dysfunction, and sometimes all 3 combined. And here you can see even depression might develop with suicidal ideation. So all sorts of things happen in our brains because the brain doesn't like it when the hormones go up and down, so severely discoordinated. The ovary is an unpredictable jack in the box in this period of time because there are still sleeping follicles. They sometimes wake up and then they try to hasten and to make some sort of cycle, and it is hard to predict what happens. What can we do in this period? And that's kind of really not so easy. Well, first thing, when we start to intervene when there are bothersome symptoms like sleep disturbance, mood swings, irritability, depressive mood, abnormal uterine bleeding. Be aware of prevention of endometrial pathology, especially when women have periods with a lot of estradiol dominance. Sometimes the women have hot flushes, but in this early perimenopausal transition, hot flushes are not the dominant symptom. That's why the women don't think of it. So I bring you a case report. That's very typical. Sylvia, not 49 years old, slightly elevated BMI, Until 1 year ago, quite regular bleeding, now dropouts, also phases with bleeding every 2 weeks, sometimes heavy, sometimes light bleeding, poor sleep, irritability, mood swings, only sporadically hot flushes, very typical. So that what you find in the lab results. It is an elevated FSH already, but it is not very high, and we still have an estradiol secretion. She was prescribed a low-dose combined patch. As a result, she bled even more irregularly. The other complaints did not appear either. So what could you do in this case? With a low dose combined patch, you won't do anything. The rising up and down and the roller coaster persists, and it is just on a higher level. So what you can try, cyclic progestin administration, or a low dose sequential preparation. But you see, the progestin is really important. Or you can use an LNG IUD and intermittent estradiol adding, but this won't help you with these mood swings, depression, and irritability. It will fix the bleeding problems, but it will not prevent fluctuations in ovarian activity and these loop events with the resulting complaints. Sometimes only one thing helps. Press the brake and step on the gas at the same time. What do I mean with this? So you need a progestin with anti-gonadotropic property to suppress the deregulated pituitary ovarian axis. And when you do this, especially in this period of time, you may have to add an estrogen, because the suppression may cause estradiol deficit on the ovary. So that might be the case. So what can you do? You can use a classical combined hormonal contraceptive, which is often contraindicated in this period of time because of vascular risks. You can use a progestin-only pill, a POP, or other progestin with anti-gonadotropic properties, plus estradiol if needed. Sometimes you even have to double the doses of the POP to achieve a sufficient suppression, which we can see very often. Important is the higher the progestin dose, the stronger the anti-gonadotropic effect, the suppressing effect. And so you can really vary the degrees of slowing down the follicle maturation. And it really depends on the case, and it's very, very different. So that would be a follicle, no break at all, so full speed. And that is half break, like what you do with the POP. There's still a bit of estradiol production, or you have a full break where there's no estradiol production anymore because you have suppressed the ovary, and then you have to add an estradiol. So how do you know how much you push the brake? And that is the ovulation inhibiting doses. And I know that not in all countries of the participants you might have all these substances, but you can choose from those. So this would be the dosages that are needed to really kind of push the brake fully. But most important, micronized progesterone and diprogesterone are beautiful progestins, and they're wonderful in the postmenopausal period. But in this period, when the ovaries are out of control, they don't have sufficient anti-gonadotropic effect in the usual dosage. Which is most important, during this period, because of a very changing ovarian activity, you have to keep in mind that you have to see the patients on a regular basis because monitoring is essential. And you always have to be able to adapt the procedure to the respective situation of the patient, which might change every 2 or 3 months. So there's a change all the time that you cannot predict. With this, I'm at the end of my lecture. It is very important to have an individual decision, as every woman is unique. And now I thank you for your attention. Susanna, yeah,
thank you for your talk, Katrin, for your brilliant presentation. We do the Q&As at the very end of the session. Now I would lead to Annette. Dear Annette, I hope you are there.
I'm here.
So we know that good data on peri- and postmenopausal women with PCOS are rare. So what can you tell us about this?
Indeed. Thank you very much for the invitation and the kind introduction, Susanna. And as you said, we really truly enter unknown territory when we ask the question, what happens to PCOS patients when they enter peri- and postmenopause? Good quality data are rare, as you've said. This is quite astonishing because, let's go on. Let me start this. Okay, let's go further back. I'm starting my presentation in a minute. Yes, now everything works. I don't have any specific conflicts to declare. And as you said, we enter unknown territory. And it is quite astonishing how little we know, because PCOS, polycystic ovarian syndrome, is the most common endocrine disorder during reproductive age. 8 to 14% of all women are affected. And yet, we don't know what happens when they age. What we do know is that PCOS is heterogeneous and hereditary. We know over 40 gene locations, but yet the mystery of the pathophysiology of PCOS is not quite solved yet. We know there are signs of neuroendocrine regulation disturbances. We know that there are problems with fat tissue and metabolism, with ovarian and adrenal steroid production, with steroid hormone action and insulin action. From what we know, or from our understanding now, PCOS is very heterogeneous because we have an interaction between hereditary factors and environmental factors. One of these environmental factors is our microbiome. So for PCOS patients, it is as true as for all of us, we are what we eat. There are not only various phenotypes of PCOS, we have also had various diagnostic criteria of PCOS during the times, which gives us the great problem of comparing results of all our studies. All the diagnostic criteria only have one thing in common. They're only valid during reproductive age, which means PCOS can only be diagnosed during reproductive years. Leading symptoms of PCOS are bleeding disorders, of course, infertility, hyperandrogenism, and cosmetic problems related with that. It's a little less known that we also have a 3 times higher risk of depression, anxiety, and eating disorders. 60% of PCOS patients live with obesity, 70% are affected by insulin resistance. According to the newly updated International Evidence-Based Guideline Criteria, AMH is also a new diagnostic feature, but we don't know which cutoff levels to use. And AMH is very useful in many ways, but not in all. We have tried over and over again to establish the duration of reproductive life according to mathematical models using AMH level. And for PCOS patients, one of these models here based on a cohort out of the Perimenopause and lipid and glucose study has established a reproductive lifespan, which is 2 years longer in PCOS patients. However, unfortunately, confidence intervals are large and overlapping. This study from Sweden was part of the MONICA study with 27 PCOS patients. They entered the study at age 29 and were re-examined at age around 52. They were diagnosed according to NIH criteria. in these PCOS patients, menopause was even later, 4 years later, compared to their controls. And that's a nice fun fact. They had the same number of children as their healthy controls. So that's really good news for PCOS patients. They might have a longer reproductive lifespan, and they can have as many children as other women can have too. But those are low quality data. We have only 70 to 27 patients. And again, confidence intervals are large and overlapping. PCOS patients might be happy at the end of their reproductive lifespan with the reproductive outcome, but what about their menopausal symptoms? So there also seems to be good news. We don't have any evidence of an increased risk or any difference at all with regard to the incidence of hot flashes. The Midlife Women's Health Study was one of the latest studies showing this. There was also no difference between PCOS patients and control women for levels of FSH, progesterone, estradiol, or testosterone in this cohort. Of course, as ovaries age, androgen levels are decreasing as well. This is true for every woman and also for PCOS patients. However, we do have some data that in some PCOS patients, androgen levels might still remain a little higher. So these data from a Scandinavian study, from a multi-center case control studies with 681 PCOS patients compared to 230 controls adjusted for age and BMI. When we look back at leading diagnostic symptoms and bothersome symptoms for PCOS patients, for some, hyperandrogenemia and cosmetic problems might persist. The risk of depression, anxiety, and eating disorders also remains high. Bleeding disorders, of course, we've heard Catherine talking about that already, are common during peri and post-menopause, especially during perimenopause. And so this is not something specific for PCOS patients anymore. What is concerning is that obesity and insulin resistance, of course, are increasing problems during that age. Not only PCOS patients, but all of us undergo metabolic changes during peri and postmenopause. Some of them are changeable. Of course, we can adjust lifestyle and nutrition, but some of them, however, unfortunately, are not. We cannot turn back time, and we cannot lower E2 levels, FSH level, and we cannot prevent ovarian aging. The consequences are changes in peripheral fat tissue. We have lower rates of lipolysis and higher rates of adipogenesis if we lack estradiol. And unfortunately, which is really unfair, we have central problems. E2 has an inhibiting effect. If we have estrogen deficiency, we have a lower energy expenditure, and at the same time, we have more appetite, we have increased food intake. That's not fair, but this is true for all of us, not just for PCOS patients. The result is a change in body fat distribution after menopause for all of women, a decrease in lean body mass, and an increase in fat tissue. The increase in fat tissue already brings other problems and entering us into a cascade leading to chronic inflammation with oxidative stress and hyperinsulinemia. These two are really the true bad guys in menopause. So if we talk about hyperinsulinemia, of course, it is a very relevant question to ask about the risk of type 2 diabetes in PCOS patients during peri and post-menopause. The Tehran lipid and glucose study, again, has addressed this question. It's one of the largest long-term prospective population-based studies we have. And yet, we only have data from 178 PCOS patients and 1,524 matched controls. After a median follow-up of 12.9 years, we had very expected results. The risk of both prediabetes and diabetes goes up with age. What is surprising, though, is that for young patients, the risk for PCOS patients to have prediabetes or diabetes is still very much higher compared to normal controls. But as we enter perimenopause, you can see that these differences really lose statistical significance. So does that mean PCOS patients are healthier the older they get? No, it's just the healthy controls get less healthy. Nonetheless, there are not so many or as many metabolic problems as we might think. What about the risk of cancer? We do know that there is an elevated risk for endometrial cancer in PCOS patients. We have good data on this, and we particularly have to have an eye on our young perimenopausal PCOS patients, as they have a particularly increased risk of endometrial cancer. With regard to ovarian cancer, results are conflicting, and as from what we know now, there is no elevated risk for breast cancer. But we have to keep in mind the risk of cancer increases with BMI, and we have a relative risk for cancer for a BMI above 40 of 1.5 for breast cancer, 1.5 for endometrial cancer, and 1.3 for ovarian cancer, and really an elevated risk for almost any cancer there is. We have talked about metabolic risk. We have talked about cancer risk. So it's time to look at the #1 cause of death, which is cardiovascular disease. In a meta-analysis from 2020, we have results from 10 cohort studies from 1964 to 2020 with more than 160,000 samples. And indeed, the results show PCOS patients have a significantly increased risk for cardiovascular event, myocardial infarction, ischemic heart disease, and stroke. However, there was no statistically significant difference in overall mortality and CV death. You might ask, what do we do with this information? How can we help our young PCOS patients to set the right path for later? And how can we help our aging PCOS patients with this information? The answer is very simple and yet very difficult at the same time. The answer is we have to optimize weight, nutrition, and lifestyle. We can use specific, measurable, attractive, and realistic goals, smart goals. Whatever we use, we have to start moving more and increasing muscle tissue. The good news is a weight reduction of 5 to 10% already has a positive impact on all features of PCOS. If hyperandrogenemia and cosmetic problems still persist, we also have other therapeutic options. As our guidelines says, topic therapies are #1 choices, regardless of age, electrophotoepilation or topic therapies like eflornithine or minoxidil. Progestins, we've already talked about that, are an option. Of course, oral contraceptives, not so much with regard to elevated cardiovascular risk factors. Spironolactone is an off-label second-line therapeutical option. Finasteride is also possible. We just need to make sure there is safe contraception. Insulin sensitizers such as metformin, off-label use, of course, can have a small androgen-lowering effect. They don't have any effect on weight. Our biggest hope is the use of GLP-1 agonists. They, of course, help to reduce weight at the same time. HRT is very important to help treat symptoms, menopausal symptoms, hot flashes, and so on. They have to be tailored towards individual risks and metabolic needs. And of course, we need to have a great eye on endometrial protection while using them. I conclude, PCOS patients in peri and postmenopause might have a prolonged reproductive lifespan. We don't know, really. They undergo all the changes any other woman during menopause experiences. And as the perimenopause gets things out of order, so are the leading symptoms of PCOS. They change. Some women might still have persisting problems with hyperandrogenemia. They show a decrease in lean body mass and increase of fat tissue. They have an increasing risk of type 2 diabetes. We should not forget that. We have an increase of cardiovascular risk and a risk of endometrial cancer. Our patients need empowerment for optimal lifestyle choices and a particular focus on endometrial protection. Thank you very much.
Thank you, Annette, for your wonderful talk. I saw we already have some questions in, as I would now start the Q&A session. So there's a first question. I think it's to Katrin. So Miruna asks, hello, Dr. Schaudig. How can we approach a woman at 48 years of age with 5 menstruations per month in the last 3 to 4 months? How to start the investigations and which treatments would be useful? Thank you.
Yeah, that is a very good and important question, and it describes a patient that we might see very often. Well, first of all, if there are 5 bleedings within a month, of course, we always have to rule out endometrial pathology. So we really have to have a close look, like with the sonography of the uterus, if there is any hint that there could be a pathology within the uterus, which might be a polyp, an endometrial polyp, but it could also be, of course, endometrial cancer. So it really depends on how the whole patient is. Is she obese? Does she have diabetes, hypertension, all risk factors, or does she have a long-standing PCOS, Annette, like the patients you described? So I think this is something of concern. We have to decide that. If we think the risk that there's really an endometrial carcinoma or something like that is low, then we just would try to treat them with hormones. And I think a POP would be the proper thing at this moment. I mean, you could also start an LNG IUD because the bleeding problem obviously here is the dominant thing. So start with the LNG IUD. That would be one choice. The other choice would be start a POP. And I think just that there are no studies toward that. I might even think about starting a POP with a double dose, because I would think she probably has a lot of stimulation from her pituitary gland, and then you just have to wait what happens and kind of get these ovaries that are probably out of control into a normal rhythm. So POP, maybe double dose POP. If she doesn't have a contraindication, and combined oral contraception would be also one of the possibilities.
So thank you so much. There are many questions now. Miruna has a second question. This is maybe to both of you. What is the mechanism of hyperandrogenism in lean PCOS patients? So not in the overweight ones.
Annette, I think I forward that to you.
Well,
it is your topic.
Well, that is a very good question. And I have to give you a very disappointing answer. We don't really know yet. So the pathophysiology of PCOS is quite a mystery. And the only thing we can say, there is no such thing as one mechanism causing that. So on the one hand, we might have problems with the adrenal glands, okay, and at the same time we can also have problems in the ovaries with production of androgens, okay. Anovulation, of course, doesn't help because we have all the androgens which will never be turned into estradiol. And so these women enter into a vicious circle when we have more and more androgens in our ovaries and not so much turnover. And at the same time, the androgens block further development and ovulation. So it's quite a tricky question. And the problem just is, or the good news is actually, during perimenopause, all of these problems actually do get better. So androgen levels are decreasing, maybe a little slower in PCOS patients, but they're still decreasing. So we just need to find symptomatic treatment. Okay, so the younger the patient, the more likely we can give her combined oral contraceptives with full force of atenyl, estradiol, making sure those androgen levels are low. As they age, we can give progestins with anti-androgenic effects, still without the estradiol, and help us like that. I hope that was sort of sufficient, but it's a very difficult question.
It is indeed. There's another question for you, Annette. Not such a hard one, but strategically one. So Val asks, Dr. Bachmann, given that PCOS patients tend to have an increased risk of eating disorders, how do you recommend safe weight loss interventions to these patients without even contributing to this increased risk for eating disorders?
Yes, that's also a very, very relevant and important question. Thank you for that. And I think this specific question shows us that we really need an interdisciplinary approach. We need specialists. So we need to work closely together with psychiatrists and nutritionists to find a very individual way for each person. Because there is, as heterogeneous PCOS is, as heterogeneous is the group of women with eating disorders, and they need an individualized approach, but not without the expert advice of psychiatrists and psychotherapists at the same time. So we need to, we have that in our team. We just work closely together to build up healthy habits while at the same time making sure. But it's a struggle and it's a challenge.
So thank you. Next questions. Victor Manuel asks, how to treat women with breast cancer or cervical cancer and who have genitourinary symptoms? I think this is a general question.
Maybe, Susanna, you can answer it.
I mean,
we don't want to leave you out of the play.
Out of the discussion. Yeah, how to treat women with breast cancer. I mean, there's a new group of medication, at least in Switzerland, now on the market. It's the big group of the neurokinin 3 receptor antagonists like fezolinetant. There are studies going on about elanzina. Now I'm hanging. Elinzanetant, yeah, which make a symptom reduction of about 60% already after a week of vasomotor symptoms. So this would be one way to treat women with breast cancer if hormone replacement therapy is not allowed. And in women with genitourinary symptoms, I would use local estrogens, for example, or local dehydroepiandrosterone, DHEA. Or in the US, there's also a medication on the market which we don't have here in Europe, which is called ospemifene. It's a special type of serum. Yeah, Katrin, do you have any other ideas?
No, it really, I think the question is, what is the condition of the woman? Does she have hot flushes or is it a bleeding disorder? And sometimes we have the problem even in bleeding disorders. We have to find some way to treat them. So when these women become perimenopausal, we have to do something. So even sometimes we have to add hormones just to regulate the problem. Don't you think so? So I mean, it's a very hard decision and you have to do that with the patients together. But sometimes it's just the only way to get rid of these bleeding disorders, at least for like 3 months or 6 months. And I think you won't do too much harm. That's I think something when it's the bleeding problem.
Exactly. Sorry, I thought that the problem would be vasomotor symptoms. That's how I answered the question. I did not know what symptoms Manuel meant. So he sent another question. Is there an age to treat menopause? And what does the term peri-menopause mean? So, I mean, do you want to answer this, Katrin?
I mean, the average age of menopause is 51, and the women start to have complaints like I just described, like mood swings, irritability, like maybe 10 years earlier. And some women who start with this process even earlier, like in the late 30s. You have to just, first of all, you have to diagnose it. It's not just that they're getting crazy or insane, they're just perimenopausal. And I think this is very important. I think the main thing is you have to explain it. And then it really depends on, well, the burden they have, the burden of symptoms they have. If they say, I don't want to suffer anymore and I can't stand that, then you start treatment, as I explained. Very often you would only start treatment when they're around menopause or in postmenopause. That's when mainly because they have hot flushes, also sleep disturbance. I think it's always, you start treating them when they have bothersome symptoms that they cannot tolerate anymore. And that can happen even later. So I sometimes see patients, actually I saw one today, who has been suffering for like 6 years after her final period. And then she showed up and she said, well, one of my friends went to see you and can you help me? And I said, well, you have been sweating now for 6 years. You are still heavily sweating and you have sleep disorders. Well, and then we started her. In this case, you don't need a progestin with anti-gonadotropic effect. You just need a progestin that kind of takes care of your endometrium. And in these cases, we are happy to use progesterone or dydrogesterone in combination. I would also always start with the transdermal estradiol in this case. And then we started, and she just came back and she said, well, if only I had known this would make my feeling and well-being so much better, I would have come earlier. And so she was afraid of hormones. So I started her. She's now 57 or 6. So you can even start then. And there are some women who continue sweating even beyond their 70s. And it's always an individual decision then. If there's a load and a burden of suffering, I would always kind of consider hormones. But you do have to make sure that the symptoms the women have are really due to menopause and to an estradiol deficit. You know, like a woman starting sweating 10 years after menopause, she doesn't have a hormone deficit. She's, for instance, sweats or has hot flushes because, for instance, an insulin resistance, maybe because she has hypertension, whatever. So you have to find out, does it have to do with the hormones? And then you can treat them. Then I think there's no limit. The older the woman becomes, you have to really use transdermal estradiol to minimize vascular risks. For us, women over 60, we would always treat with transdermal estradiol because from the age of 60 on, the risk for thrombosis rises exponentially. So, and also the risk for stroke. So that you have to consider, but otherwise I don't see a really age limit.
Yeah, I think the question was also asked when to start. You start when you see a woman who has problems, and if she's only 42 years old and you're not sure if this is already menopause or not, and the hormone levels is quite normal still, normal estradiol, normal FSH, but you have the feeling that this might be a climacteric syndrome. Hey, you start it, you try it out 2 months.
Yes.
There's no risk in trying out. Let's see if it gets better. If it gets better, this was it. This was the right diagnosis.
Yes.
If not, you stop it. You search what the problem is. So you don't be afraid of trying out. I have to close this session now. I thank you so much to the speakers, and also thank you so much to the listeners for listening to our educational session, which I have to close now because of time. I hope to meet you again. This was a pleasure. Bye.
And thank you, Susanna, for moderating so beautifully. Thank you.
It was a pleasure. Thank you so much. Bye.
Bye.